Well, good afternoon, everybody. My name is Lenny Enzel. I'm a retired Army Nurse Corps officer and honored to be the moderator for this session with my old colleague, Colonel Ed Yackel. Ed has his doctorate from Duke University, and he is a fellow in the American Association of Nurse Practitioners. He has a long quality assurance, quality improvement career, both in the civilian and the VA and the Army. And he has consulted, he has published. In fact, we were just talking about an article that he's working on. He's currently serving as the senior executive at the VA's National Center for Patient Safety, which I think is a great way to approach safety. And he is the first nurse to be in that role, which touches my heart. So a few rules for our webinar. This is our 6th Army Nurse Corps Association webinar. We will go on a little hiatus over the summer and hopefully start up again in the fall. I ask that everybody mute your mic so that there isn't any background noise. We are going to entertain all your questions in the Q&A section. So you should see Q&A. Please don't use the chat, use the Q&A. This will be recorded, and as with all of our previous webinars, if you are a member of the Army Nurse Corps Association, it will be available for you to view on our website. If you are not a member of the Army Nurse Corps Association and would like to be, it's a mere $40 every 2 years, and you can sign up on our website. I think that is it for my introduction. We will unmute at the end, and if you want to ask a question of Dr. Yackel and not type it into the Q&A section, we will have that opportunity. But I'm really excited that Dr. Yackel has agreed to present to us today, and I will turn it over to him.
Great, thanks so much. Great to be with all of you today. I'm not seeing the slide deck, Nikki. Lenny, are you seeing the slide deck?
I am not. I saw it when we started. Let me see.
Please stand by. We are experiencing technical difficulties. I'm glad to be here with all of you today, and hopefully I can share with you how you can move from your military career into a career in the Veterans Health Administration. As a reminder, the Veterans Administration consists of 3 main branches: the Veterans Health Administration, the Veterans Benefits Administration, and then the Veterans Cemetery Association. And so the VHA is one part of that, and the secretary right now is Secretary McDonough. Again, I wanted to let you know that there are several new initiatives to hire nurses within the Veterans Health Administration. Interestingly, what I want to let you know is that the VA, the nurses and other providers within the VA have started, we started towards a pathway of having better pay for nurses. And so the Chief Nursing Officer, Beth Taylor, has worked with the Biden administration, and we should be seeing pay raises for our nurses. That'll be important when I show you the slides about how many positions we have empty with or waiting to be filled within the Veterans Health Administration. We're also looking at when you practice, I'm a nurse practitioner as well. And so when you practice in the Army, you basically have immunity. And so we're looking at that, no practice restrictions. In the military, they're looking to do the same within the Veterans Health Administration. They're a little bit behind the Army, Air Force, and Navy, the Defense Health Agency, in terms of that federal supremacy, but they're working towards it. There are still objections from certain avenues, like the physician who are anesthesiologists, but the American Nurses Association and other organizations are actively campaigning for federal supremacy. So we'll talk more about that in a little bit. Next slide, please. So as you consider retirement, whether it's at 5, 10, 15, I was in the Army for almost 30 years, make sure that you are linked with a veteran service organization. When you get ready to out process, you'll be scheduled for a series of briefings, and in that they'll tell you how to file for VA disability, your benefits. They'll make sure you have all your forms, you'll walk you through it. At that point, you'll have contact with a veteran service organization. I was very lucky to be able to be connected with the Wounded Warriors program, and they assisted me in filing my VA disability package. Do that proactively and start 6 months before you begin to leave the military. And give yourself, as you begin that transition, please remember to allow yourself to rest and relax for 6 months, recharge your batteries. About 6 months, I was climbing the wall, and then I decided, hey, I need to do something else. When I was looking at what I want to do, and I thought about, well, do I want to go back and be a family nurse practitioner, burn and churn? I decided, well, maybe that's not the pathway for me. And then I saw a job pop up on USA Jobs that said they needed someone in patient safety, a deputy executive director for the National Center for Patient Safety, which is located in Ann Arbor, Michigan. So I said, hey, that sounds pretty cool. So I applied, and I'll show you kind of what you have to do to make your application adequate. Before you apply, you want to have everything, all your documents gathered. Your DD 214, that's the form you have when you get discharged. That calculates all your military time, your curriculum vitae, all your references, 3 to 6 references, your previous work history, all the addresses, the homes you've lived in, prior security clearance. They're going to have you reapply for your security clearance. And then they'll ask for all your licenses, certificates. So they'll want copies of all that. So just think of it as being credentialed and privileged in an organization. This is exactly what is going to happen when you apply to the VHA. Next slide, please. What the next slide will show you is a military versus civilian CV. This is mine. Working with a veteran service organization, you'll have to create a CV that looks professional and really highlights the strengths you bring to the table. On the left is a traditional CV you probably all have. On the right, working with the veteran service organization, I was able to have someone help me. I think I paid the individual $150 to help me transform my military CV to a civilian CV and look very professional. Next slide, please. Before we go into the vacancy map, one of the things I wanted to let you know is that when you're applying to the VA, you'll see job openings, and they'll have a bunch of characteristics: leadership, communication. There are a host of them, what they're looking for. When you're building your CV, you want to make sure those keywords appear in your CV, in your job application, because they use a computer to search CVs to pull out those keywords. And if those keywords are not in that CV, then your CV will not make it to the next step. It will not make it to the referral list. So I just wanted to make you aware of that. What you're seeing in front of you is the vacancy heat map for nursing, which is current. And you see all the dots. There's currently a 17% vacancy rate. The reason I'm sharing this with you is that across the United States, there are shortages in nursing, as many of you might be aware. As the baby boomer population ages, we won't have enough nurses. So we have to think creatively on how to bring nurses into the workforce and then retain them. Next slide, please. The next slide will show you RN hiring through 2000, the hiring needs for the VHA for advanced practice nurses and RNs through 2026. And you'll see the darker purple areas are the areas of greatest need. So if you decide that you're going to live in one of those areas, you probably have a really great chance of being hired into the VHA healthcare system. And I'll let you know, it does have a lot of benefits for it. There's a GS system. You can be a GS 13, 14, 15, or an SCS. And there's a great benefit package too. There's thrift savings plan that they match you dollar for dollar, etc. So next slide, please. I also wanted to make sure we include our LPNs and nursing assistant colleagues, and this also displays the heat map for those vacancies through 2026. Again, in about the same distribution, although I think you can see Michigan is a deeper purple than the rest of the areas. Next slide, please. So how do you get employed? How do you do that employment within the Veterans Health Administration? Really, I would encourage you to go to USA Jobs, click on that website that's been provided, and keep searching, look through it, and click, really get familiar with it, because then you'll become better acquainted. I found it pretty user-friendly when I applied. You have to be honorably separated to be able to be eligible for veterans preference. And there are 3 types of veterans preference, and I've provided the web link here for you. You can apply it as a disabled veteran, there's a 10-point preference. A non-disabled veteran, there's a 5-point preference. And the sole survivorship is for those who survive a veteran passing. Look for the symbol displayed, that green symbol, that means there's veterans preference. And that will help you as you're in USA Jobs. You can look for that green shield, and that'll focus you on there. And then you can filter by nursing positions, leadership positions, etc. You will have to have your DD-214 and complete a form, which is available online, to determine your 10-point eligibility. It's really, really easy. Again, but have your forms available. Next slide, please. There are other specific veteran hiring options. So there's a variety. If you're really interested in being employed in the VHA, there's such a variety of employment opportunities, and they really are trying to recruit former military nurses. So again, if you decide to get out in 5 years, 10, 15, 20, 30, they're looking for nurses, and they have a wide variety of tools to bring you into their workforce. So the veterans recruitment appointment, you'll be able to get all the information from the link on the bottom of the slide. But in this one, this is for people who are GS 11 and below. So if you are going to take a position and you think it might be a GS 9, 10, 11, this is where you would go to have that hiring option. There's a 30% or more disabled veteran. If you didn't make the 100 or 50% mark that you saw in the previous slide. And then just being aware of different laws like the Veterans Employment Opportunity Act of 1998. And then the final thing, there are training programs for disabled veterans that the VA hosts that you can get into. If you happen to be a newer nurse, there's a mentorship preceptorship program within the VHA, just like we had in the Army Nurse Corps. And there's a transition to practice program. So I think that was really cool when I discovered that. So next slide. So let's talk about being a senior executive service. I am a senior executive service. I'm a Title 38 equivalent, and we'll explore that in a minute. But a lot of people don't even know what a senior executive service is. So this is the group of folks above the level of GS 15. We're the federal employees who serve as executive management for federal agencies. So think of all the federal agencies, FDA, etc. So we provide institutional stability across administration. So that means as we change presidents, we keep the government running, and we serve a link between political appointees, frontline managers, etc. So when I first came into the VA, we were transitioning from the Trump to Biden administration, and there are political appointees in all the federal agencies. As the president changes, those political appointees leave their positions, and other political appointees enter those positions from the incoming administration. And that process can take quite some time. Next slide. So I did mention that these are above the GS 15 level. level 3 of the executive schedule. So think of the Secretary of State, they're SES level 3 or above. So it's sort of inversely ranked. And you can see here that 10% of SES positions can be filled by those political appointees and novice. There's about 8,000 SES folks in the federal government with 75 agencies. And I thought that was really interesting. What I would also talk to you about is that you don't have to go with the Veterans Health Administration. There are 75 agencies, and there are many medical related, nursing related agencies out there, people who need advice or consultancy. So do think about that as well. It is a pay for performance system and has fewer protections. I serve at the behest of the deputy secretary, the secretary, and I can be fired. I'm not a member of the union. I have to have an SES performance plan. I have to achieve my performance plan and show evidence of that. And there's an agency called CHSMO. I won't tell you what it stands for, but Senior Executive Office, that helps build those plans. And so right now we have major initiatives on culture, diversity, inclusion, and then making sure veterans access to care. And also you'll see in another slide about taking care of our women's veterans. There's a women's health program that's become more robust, as well as homeless program. I think you may have read about some of that in the newspapers lately. Next slide. So this is Title 38 versus Hybrid 38. I won't go too deep into this, but as you're looking at these positions, you just want to be aware of what you're being hired on from. A Title V person, if you're in the military and you think of the line officers, non-medical, they could be classified as Title V. Medical people who are clinicians are Title 38, and most of those people are healthcare providers. So this is where your advanced practice registered nurse would fall. And then your hybrid 38s are the other healthcare team members who help us every day: pharmacists, nursing assistants, social workers. And so there are different pay scales. There are similar pay scales and different rules that apply to each of these groups. So I encourage you to research that. Also, as you're applying to the VA and you're getting ready to submit your CV and say you're being sent a job offer, before you accept a job offer, remember you must negotiate your salary before you accept that job. Click the button to accept that job offer. Once you click the button to accept your job offer, you won't be able to negotiate your salary. And I found that in general, with having military experience, they are very willing to negotiate salary with you. And you'll be communicating with an HR specialist who then will communicate with the agency that's going to hire, the specific department or section that will hire you. Next slide. So I wanted to show this to you. It's a little bit difficult to read, but this is just showing what the Veterans Health Affairs looks like at a glance. If you look in the upper right-hand corner, you can see that there are 9.6 million beneficiaries enrolled in the Veterans Health Administration, making us the largest healthcare system in the United States. We are also the largest retail pharmacy, and we are also our own DME company. So what does that mean? So we have, instead of things going out to TRICARE for prescriptions through Express Scripts, we have a centralized medical outpatient pharmacy called CMOP, and it's the largest one in the United States. So we are our own medical dispensary, medication dispensary, pardon me. Also, we are our own DME company. So think CPAP supplies, et cetera, et cetera. Anything DME, durable medical equipment. We actually provide that. We do not go to TRICARE for that and have a third party pay for that. That's a nuance, that we are different from the Defense Health Agency. And it's a nuance we're currently talking with our colleagues in Cerner about, as we also implement the electronic health record, Genesis in the DHA, Cerner within, actually it's something else, but Cerner within the VHA. I also want to draw your attention over to the left-hand side of this screen, where you can see that the percentage of female veterans is increasing, especially after the last few conflicts. And so that's why we have a more robust women's health program. You'll see that on that bar graph on the lower right, you will not see Iraq, Afghanistan, or the current conflicts listed because they're still collecting data on that, I would assume, and we've just exited Afghanistan. So likely they'll have a left and right boundary to calculate the numbers. And I would think that we would see, I think we talked about 30% of the veterans will be female veterans. So the Veterans Health Administration is really looking at very, very closely and how we can better serve our women veterans. I hope that resonates with my fellow Army Nurse Corps members. Next slide, please. So I wanted to talk to you a little bit about patient safety in the Veterans Health Administration. Next slide, please. So this is an eye chart. Well, what you want to know is that 2.5 years ago, the Veterans Health Administration went through reorganization. The Veterans VACL, which is the VA Central Office, went under a modernization. In that modernization, what happened is quality and patient safety were brought up from disparate parts within the organization and put underneath an assistant undersecretary for quality and patient safety. His name is Dr. Jerry Cox. He's a former Navy physician and was a former 06. Over on the left side of the screen is the National Center for Patient Safety. I'm the executive director for that. Under my organization, I have, under my division, I have 2 entities, utilization management, which many of you are probably familiar with. And then also an office that's called Optimizing Healthcare Evaluation Program. What that looks is at healthcare outcomes and return on investment and the value that our quality and patient safety initiatives bring. Think about lessons learned and spreading change over your organization instead of continually relearning what we've learned before. Office of Quality Management. So there are 2 SESs in the National Center for Patient Safety, 2 SESs in the Office of Quality Management, and then 2 SESs in the Office of Analytics and Performance Measurement. So the Office of Analytics and Performance Measurement does all the healthcare measurement, access to care, veteran satisfaction, patient safety indicators like CODI, CLABSI, VAP, and then quality measures, HEDIS, etc. So we're really a cohesive group. We're coming together. There's still some reorganization going on. Next slide. This is just the patient safety division. And what you'll see in the boxes is the description of the functions of each of the parts of our organization. So utilization management, you can see they have 600 plus field-based utilization management folks. I wanted to let you know that the VA employs over 380,000 employees. 80,000 of those about are nurses. So I thought that was really interesting. We brought that out in a discussion. And so utilization management, the veterans get what they need when they need it, and they don't stay in the hospital any longer than they need to, because we know that when folks stay in the hospital, they have more chance for nosocomial infections, more chance for error and harm. And then you can see the mission for the Optimizing Healthcare Evaluation Program. Next slide, please. Hopefully I'm not rushing through this. I'm just trying to make sure that we cover all the material, then we'll have the Q&A. So the National Center for Patient Safety was formed in 1999. It's always been physician-led, but I was able to compete for that job and just moved into the executive director job in December of this last year as the first nurse to be the SCS that leads the organization. And we're really focused on zero harm. What's really interesting about the office, though, is that we have a multidisciplinary team of people, and we try to mirror a facility. So we have physicians, we have nurses, we have pharmacists, we have biomedical engineers, human factors engineers, we have a social worker on staff, physical therapists on staff. So it's really cohesive. And we look at things from a systems perspective, because we know people don't go to work to hurt people. It's normally the system we develop that puts them at a risk of error. And some of you may have heard about the Vanderbilt case. So if you'd like to talk about the Vanderbilt case, we can talk about that in terms of high reliability, just culture. Just culture is essential pillar of high reliability, and how we would look at that using things like a decision support tool. All right, and then so again, systems approach to solving problems. So next slide, please. So these are just key programs. I won't talk over them all, but what I want to tell you is that we have a lot of initiatives centered on education, which is one of our value streams. So we have a patient safety program academy where we teach core patient safety science to our all our folks out there in the facilities and at the regions, or the VISN, which is a Veterans Integrated Service Network. Only took me about a year to learn all the acronyms, by the way. And then, so we have two unique programs that help us out. One of those is the Advanced Fellowship in Patient Safety. That is a year-long program. We have 18 fellows right now spread over the eastern and central part of the United States. We try to educate these people and give them foundational knowledge in patient safety science, also change management and high reliability. The goal is for those people to be able to leave that program and be hired as a patient safety professional. And then we have the Chief Residence and Quality and Safety Program. There are 120 physicians in that program, and the goal for that program is to make them physician champions for quality and patient safety and high reliability. Our office is very involved in clinical team training, which is how to think of team steps. It's an equivalent to team steps and how we want our teams to communicate in a non-punitive, psychologically safe culture. And then also we fund patient safety centers of inquiry. These are patient safety centers of inquiry are basically in the facilities. You have research cells, and they are studying patient safety things like falls, electronic health record implementation. So we fund several patient safety centers for inquiry. We funded 2 last year at $400,000 each. My organization's budget that I manage is $30 million. Policies and procedures, you can see the policies and procedures there. So you might be thinking, well, so Ed, what do you do besides running this program? Well, a variety of things, actually. In addition to keeping staffing, monitoring the staffing within our organization, all the HR functions like discipline, awards, the normal things you would expect. I also am the responsible agent to help set policy for the advise my assistant undersecretary in policy. I also review anything that's going to the Congress and Senate that has patient safety in it. Recently, a congressperson wrote to the deputy secretary about a concern, and I had to review that reply to make sure what the deputy secretary had his folks had written was accurate. I also prepare my assistant undersecretary to testify in front of Congress about patient safety, and I also can be called to Congress to testify. There's a Senate Veterans Committee, the SFAC, that we frequently get questions from. Recently, a lot more about the electronic health record. We also have a very robust OIG, Office of Inspector General, and the General Accounting Office. So I answer to all those entities about patient safety. Are we following our patient safety guidebook? How are we sharing our RSAs? How are we looping people back? How do we know that we have a quality patient safety program within the Veterans Health Administration? Lots of fun. I hope you know I'm kidding. All right, next slide. So this, we do a lot. Another key value stream is patient safety and monitoring reporting. So we publish a quarterly and annual report. We just published an annual report that talks about patient safety data. I won't go into, I don't have examples of that, but we can talk more about that if you're interested. We used a joint patient safety reporting system. So I continue to work with my Defense Health Agency colleagues, some of the people I used to work with in the Army, and we talk about we share the joint patient safety reporting system with the military. We also do our root cause analysis, just like the military. We have proactive risk analysis, that's PRA. We also have our patient safety assessment tool called the PSET. That helps us, that's a checklist questionnaire that helps us to look at the system before error occurs. So it's predictive, it's proactive and it's not predictive. And then we have the MEHOC, which is a mental health environment of care checklist. This checklist has been put in place in inpatient mental health units within the VHA to reduce or eliminate ligature risk. So someone being able to hang themselves. We've been very successful with this list, this MEHOC. And over the last 3 years, we've had no veteran inpatient suicides as a result of hanging. So I thought you'd want to know about that. Of course, I've already spoke about the electronic health record. That's the EHR. We have a variety of other products like the patient safety culture survey that many of you may be familiar with. What we've done in the VHA, we embedded it in our all employee survey. We did that because the response rate when you're doing surveys and they're being asynchronously sent out before was less than 30%. Now the response rate on this particular survey is over 68% response rate. And we are getting a really good indicator that our patient safety culture has increased over the last 3 fiscal years as we've been implementing high reliability. We also manage in our system alerts and recalls. So if the FDA does a recall, my office handles that recall, sends notices to the field. We also have a great program called the STAR program, the Safety Triage Assessment Repository. That is a program we have a multidisciplinary team of people come together. In JPSR, we have a check mark that you mark something for national attention. Hey, I'm concerned here that there might be a national trend. For example, counterfeit gloves and masks during COVID. There was a checkbox that was raised to national attention. We work with all the other program offices in the Veterans VACO, VA Central Office, and we developed alerts, notices, and advisories for the field. These are messages that are sent out that tells our patient safety professionals and others, you must take action. There's a dangerous piece of equipment or product out there, or please watch this for trends. So that's another other thing we do. When I said patient safety professionals, that also includes medication safety officers. So we have a medication safety program and we have 2 pharmacists on staff. Soon we'll have 3 on staff to manage patient safety. We get about 4,000 patient safety concerns a month about medication safety, and we're working with the DHA to publish a joint guidebook on IV medication safety, which will be published and used in both the VHA and the Defense Health Agency. And so we do that as a sub-working group of the Health Executive Committee, the HEC, and the Joint Executive Committee, the JEC. So that's a joint committee, a joint DoD VHA committee. And then operations runs our office. Next slide. This is just to tell you the definitions. I should probably put it first. So our definitions of an adverse event and a serious safety event are very like the DHA, DoD. So there's no surprise, and we align with, in general, Joint Commission definitions as well. We collaborate with Joint Commission, we collaborate with the FDA. We tell them when we're concerned about something. We tell them when the definition doesn't quite fit our population. The population, by the way, in the VHA is a little bit older. Think of the DHA or the DoD side is normally 30-ish, 40-ish and below. Some of us more mature people. The VHA is normally 40 and above. So we have a more chronic care versus more acute but we all engage in preventative care, of course. Next slide, please. One thing we do that I don't remember doing in patient safety in the DHA, we do SAC scoring, Safety Assessment Code. So if you look on the left side of the screen, you look at probability. Is it frequent, occasional, etc.? You look across the right side of the screen, severity. How severe is it? Catastrophic, major, moderate, minor. You draw a line and see where it intersects. This helps us look at proactively look at risk. For example, if you have 8 events that have a SAC score of 2, they happen, for example, they happen occasionally and they result in major harm, then maybe we need to do a aggregate RC, bring all those events together, look at it, and see if there's anything we can learn so we can proactively prevent harm for our patients versus waiting for catastrophic or sentinel event to occur. So I really like this because it gets you, you might hear the term left of the boom. You want to make sure you get proactive. And this is a great way to do that. Next slide. Root cause analysis is one way to do a systematic analysis. Look at the entire system to identify causal factors. And you can see when you do a RCA, it's on there, adverse events, sentinel events. And how you determine that is the seriousness of the event. And then you can see we put into guidelines any actual SAC3 or potential SAC3 we want to know about. Remember that in healthcare, we want people to report. That's great. More reporting is better because it gives us the signal we need to analyze patterns within the system. The more close calls we get, that's even better because we'd rather not see harm events occur. We want people to catch it and then as they catch it, report it, because likely there are other people in the system catching the same thing, and we need to spread that knowledge to the organization. Next slide, please. So I did mention that we do product recalls. This is the FDA recall. There's class 1, class 2, class 3. You can see the different levels here. Class 1 is the most serious recall. That's where we need to pull things off the shelf, like defective ventilators. We've been very involved in the Philips Respironics CPAP recall, for example. And that particular recall was about the degradation of foam in that product that could cause respiratory harm in the civilian population. It's a worldwide recall, and this affects a large portion of our veterans population. Next slide. I've sort of covered this with you, why reporting matters. We promote a just culture, an atmosphere of trust for psychological safety. We want to have a culture free of accidental or preventable harm. And we want people to trust us, that we wouldn't hold them accountable for a system failure. So the way we do that is we use a decision support tool, which is very much like the one I used, and we were talking about HRO when I left the Army. Next slide. And this is the clinical decision support tool, or the decision support tool. So you start at step 1, you go across the top and read, and you think about where would this fall. For example, the Vanderbilt case, you go along, do you think the person was impaired? No, I don't think that was true. They wanted to cause harm. I don't think they really wanted to cause harm. You get over here where you see the employee made a possibly fatal or unsafe choice, etc., and the system was not set up. Yep, that's probably the one. They go down to line 2. This is an at-risk behavior. Read there, the employee is actually accountable, but they're consoled. And if you go down to and if 3 other people would have done the same thing in step number 3, then normally the system. So in terms of the Vanderbilt case, Vanderbilt was probably more culpable in that case. And in that particular case, the Tennessee law was applied because Vanderbilt did not do what they needed to do within their environment. So I think she was a float nurse. She was orienting someone. They had implemented an electronic health record that was not connected to the Pyxis machine, and it was standard practice in that environment to override the Pyxis machine. So that person does have some personal accountability, though, that she did some overrides. And then what would retrain that person because of drift. That's the term, drift. Next slide. So we've come to the end of our presentation, and I'd like to spend the rest of the time answering questions. I hate death by PowerPoint. So I want to avail myself to answer any questions you might have. So Lenny's going to go ahead and read questions that may have been posted, and I'm happy to answer those.
Hi there. Let me get my video up. I have one of our attendees was unable to post in the Q&A, so she sent it to me. And she has a few questions. The first one was, how did your military experience prepare you for your VA job?
Great question. So leadership, you get all the tools you need through your military career. They were looking for a leader in this particular SES position, someone who had experience in quality and safety. Think about when I was in the Army, we helped set policy. We reviewed all the policy with the DHA in terms of credentialing, privileging, and I have knowledge of all that. They have the same kind of systems, a little different, but the same sort of systems. They're doing FPP and OPP. We're all acquainted with that. We have CC clause in the DHA. They don't have it yet in the VHA. They're using, and all those leadership tools you get in advanced course, Army War College, thinking about strategic level. I think that was also very important to understand, because as I'm advising my assistant undersecretary to look strategically at what's going on in the environment. For example, what is the president's budget looking like? Is there anything we can do to influence the next budget, working through the VHA to make sure that we're getting the appropriate resources for our programs? That's just a quick example.
Okay, now we're getting some questions in the Q&A, so I'll go to those and then go back to the ones that were texted to me. And we spoke about this. Did you say the VHA has its own traveling nurse service?
I believe it does, yes. It does have its own Traveling Nurses Association, and it's a specific acronym. It's one I haven't memorized, but they do have a Traveling Nurses Association within the VA. We also have a fourth mission within the VHA that many people don't realize. And so we supplement the civilian sector when, for example, we had civilian patients, non-military or veterans in our hospitals. During COVID, we also sent people from our local VAs into other people's hospitals. And we also deployed during COVID people, as the waves were going, as the East Coast lightened up and those hospitals were no longer inundated, some of those healthcare teams went to the south or north or west as the waves went through the system. So that fourth mission is really important. And I think Congress and the secretary are looking at expanding that fourth mission. There's a system called DEMPS that you would volunteer in to do that fourth mission. And you keep your job. You just go for whatever time you need and you come back. Sort of a deployment module.
Thank you. And I do know a retired Army nurse who is a former VA nurse and is now one of their travelers. I believe you have to work 6 months out of the year. And she's really enjoying moving around the country. She's been to California, Arizona, I forget where else.
Yeah.
Okay, so Lindsay Drysdale said, is there an opportunity to do a career skills program internship with the VA healthcare system prior to separation?
I don't know. I don't know. There are actually a lot of fellowships. But I think probably it's a negotiation, right? You have to ask your current boss if you're going to be able to take time off to do this fellowship. But I think if you are getting ready to separate, you've dropped your papers, you have a retirement date, and you have 3 months of transition, like your sell back time for all the leave you accrued, that might be a good time to think about potentially sticking your toe in the water for opportunities like that. And those are also on the websites, and they're frequently advertised in many different forms for those different levels of fellowships. I'm not as familiar with that, though. I'll have to be honest.
Yeah, I do know that one of our local retiring colonel nurses did a career skills program at a local hospital. I don't remember hearing about them when I was in VHA, but that may be a great way to recruit more military nurses.
Yeah.
Beverly Inocenio asked, will the slides be available and emailed to us? They will be on the ANCA website next week if you are an ANCA member. And if you're not an ANCA member, we invite you to join us if you are eligible. Teresa Parsons said, from the patient safety perspective, what is being done to shorten the average length of time to recruit VA personnel?
Great question. They put in an expedited, aloha, by the way, Teresa Parsons, I wore this shirt just for you. Just so you know. So actually there's expedited hiring. They've been breaking down barriers, and I believe they can bring on nurses within 3 weeks now. And so it's the clinical people, not the SES people, nor the administrative people. It's still the same sort of 6-month back and forth kind of thing for those. But for the clinical people, if you want to be clinical, you can get in the door a lot faster. They've lowered a lot of that, especially because of COVID and needing to onboard people. I think it's less than 3 weeks to get someone in the door, work-oriented, working, credentialed and privileged, make sure you're licensed. I believe that's what I was reading. So
that's great.
Yeah.
Okay, let's see. Another question I got. You are an FNP. Do you miss direct patient care?
I do, but I've taken the opportunity. I volunteer at the University of Michigan as a adjunct, non-paid, can't be paid because I'm an SES, but a non-paid faculty. So I'm currently mentoring 2 DNP students in their capstone courses. I teach. I've been a guest speaker at it was World Health Day, so we're talking population health, world health. So I spoke at that as a panelist. I've also teach every spring and every fall on acute and chronic GI problems. And then I've been a speaker twice at different events talking about my military career, and one at a culture, diversity, inclusion event for gay LGBTQ plus folks.
Great, thank you. So another question, does the
I'll just say
VA
this, I'm still active in FAANP. I'm still presenting. I'll be presenting in June on this. So I'm staying active there. I guess I'll get back. I do occasionally miss patient care. And so that I would say that as well.
So this person wants to know, did the VA go through Joint Commission?
Yes.
And
They
then
use Joint Commission, and they use they use the lab part, the lab's clip or clap or whatever it is. CAP, that's it. Yep, they use, so yes, they have to do Joint Commission as well.
And then when there are reports of poor quality of care at a VA hospital, do you become involved in that?
So we allow the facility, just like you would allow any, like Brooke Army Medical Center, to do their own evaluation. And then the region or the VISN would then have oversight of it. It comes to my office if there is a trend, like these things are happening in 3 or 4 different hospitals. And but occasionally we do get involved. For example, there was a concern raised in one of the hospital systems that they weren't following the appropriate processes for root cause analyses. The OIG got notified through a mechanism, and then my office was identified to go to that facility to help them improve their patient safety program and teach them about how to do RCAs. So hopefully that's helpful. It's not. What I would say is there's been a lot of drift during COVID, right? We're bringing a lot of people into the force in terms of new employees. They're put on strange wards and strange situations. What we saw during COVID was quality and safety people were removed from quality and safety and sent back to the bedside. So no one was watching that. Interestingly, nationally, what we're seeing is that the rates of CODI and CLABSI, so central line associated blood infections, et cetera, are increasing across the nation because people who are in emergency mode, who are trying to save lives, are not doing those infection control things, and those bundles we put into place 10 years ago now, I think, anyway, so we're watching that as data. And also, by the way, Medicare, Medicaid, and other organizations that collect quality and safety data suspended collection of that data during the worst part of COVID. So we have a 6 to 8 month gap in our data nationally across the nation. In terms of care, VA is at par or better than civilian care in most quality and patient safety measures. And it's been proven time and time again. I would also say to folks that, that Colonel Carolyn Bulliner, who is retired now SES, and Lucretia McClenny, who's retired 06, is an SES, and she was just assigned to the Air Commission. And those are both Nurse Corps officers who had SES careers. I'm sure there's more that I'm not aware of. But Colonel McClenny, retired McClenny, is on the Air Commission. And so the VA is going through a BRAC, base realignment and closure. Essentially what's happening is some of those VA facilities are really, really old and not very safe anymore. So they'd like to close them down and build new ones where most of the veterans live. For example, in Battle Creek, Michigan, we have an old VA, and they'd like to close that one and build a new one in Grand Rapids, Michigan, just for example. So I thought, that's a long process that'll take years and years of going back and forth with the congressmen and senators and all that business.
That was a great presentation, Ed. I spent 7.5 years in the VA and I learned a few things. So thank you for that. We have our ANCA convention coming up in October. So I hope people will be able to join us. If you want to get more information or register for that, again, go to the Army Nurse Corps Association website and it's all there. And this presentation will also be there in a few days, as well as the previous presentations we've had